morning. I would like to thank to the binding site for the kind invitation and the opportunity to share with you some aspects about the use of Hevylite in the multiple myeloma. My name is Rafael Ríos. I'm working at the University Hospital of Puerta, Hierro, Majadahonda, Madrid. These are my disclosures. I have divided the session in 4 sections. First, an overview of multiple myeloma. Second, the Hevylite test. Third, the immunoparesis. And 4, new challenge. Let me start with the overview of multiple myeloma. Multiple myeloma is a devastating, heterogeneous, and very complex disease. The incidence in Spain is about 6 new cases per 100,000 inhabitants per year. Virtually, all patients with multiple myeloma have presented previously a precursor disease. Basically, monoclonal gammopathy of uncertain significance, MGUS, or a smoldering multiple myeloma. In the last classification of lymphoid tumors last year, multiple myeloma is located in the category of plasma cell neoplasms and other diseases with paraproteins, and in the family of plasma cell neoplasms. As it's the case with many other malignancies, multiple myeloma, its origin is an immune escape, which leads to the proliferation of a plasma cell clone. In the case of multiple myeloma, we have to demonstrate more than 10% of clonal plasma cells in bone marrow. These cells secrete a monoclonal protein in both serum, urine, or both. The treatment of multiple myeloma is intended to achieve a response. And finally, we have to achieve also an immune recovery. The prognostic factors of multiple myeloma can be divided in 4 main groups. The first one is related to biomarkers of tumor biology. Here we have a myriad of biomarkers. For instance, the cytogenetic abnormalities, renal function, and interestingly, the immunoparesis is located here. Second group is patient-related factors such as age, sex, race, socioeconomic status, performance status, and others. The third group is staging, and the fourth is response. Currently, response is focused on the achievement of a minimal residual disease negativity with next generation flow or next generation sequencing. Mass spectrometry could have in the future a role here also. From the secretory point of view, we have several types of multiple myeloma. There are a non-secretory multiple myeloma, which is very rare. We have an oligosecretory with a low level of M protein, but the vast majority of multiple myeloma patients have a secretory multiple myeloma. It can be only light chain in 20% of a secretory myeloma with an intact immunoglobulin. We have in the clinical laboratory 3 types of tests to the workup of a monoclonal gammopathy. On the one hand, we have the conventional methods, proteinogram, immunofixation, free light chains, and the immunoglobulins. We have emerging methods like mass spectrometry, and in the middle we have relatively young methods like the Hevylite. The difference is the sensitivity. The Hevylite tests have a higher sensitivity when compared with conventional methods. We move to the Hevylite test. This test is based on the recognition of a special epitope in the middle of the light and the heavy light chain. This allows us to recognize the 6 pair of immunoglobulins. The test gives us the information in the similar way to the free light chains. We have the involved pair, monoclonal. We have the uninvolved pair, polyclonal. And we have also the ratio and the difference between the 2 pairs. This is standardized with the normal range. In this timeline, we can see the evolution of the Hevylite test. It was first described in 2009 by Dr. Bradwell. Thereafter, several studies demonstrated that the test had an impact in survival, both overall survival and progression-free survival. In recent years, in 2016, the International Myeloma Working Group described the potential role of Hevylite at this moment, but the information by this time was limited. In the same year, Dr. Ludwig demonstrated for the first time that the uninvolved pair is an independent prognostic factor for overall survival. The next year, the French group of multiple myeloma in a clinical trial demonstrated that the Hevylite was able to better discriminate the standard response of the patients, particularly in patients with standard very good partial response. 2 years ago, my colleague, Dr. Garcia de Beas, presented a very interesting study, demonstrated that the uninvolved pair for the first time was related to the risk of bloodstream infection and also early mortality. Two years ago, we had the opportunity to review the role of Hevylite in the management of multiple myeloma. We propose to integrate the Hevylite test with the conventional methods. In the diagnosis of multiple myeloma, we have a immunofixation, but the Hevylite chain ratio is a probably better biomarker of monoclonality because the tests have a better sensitivity. In the response management, in the monitoring of the patients, we can use the difference between the both pairs, involved and uninvolved. In the precursors diseases, like MGAS, we can use the uninvolved pair to assess the risk of progression. Of course, Hevylite has been tested in all the monoclonal gammopathies, from amyloidosis to Waldenström to cold agglutinin disease. Even it has been used as a surrogate of MRD. We are talking about to the core of this talk, which is the immunoparesis. We can measure the immunoparesis by the classical immunoparesis, which is a reduction below the lower limit of normal for one or more uninvolved immunoglobulins. But also, with the help of the Hevylite, we can measure the isotype match immunoparesis, IMI, which means a reduction below the lower limit of the uninvolved pair of the same isotype. It can be severe, less than 50%, or extreme, less than 19%. In the bone marrow, with the evolution of the monoclonal gammopathy, we can see a different proportion of normal and clonal plasma cells. In this regard, in multiple myeloma, most plasma cells are clonal. In the MGAS patients, most plasma cells are normal. In a similar view, in the peripheral blood, we can see a different proportion between the uninvolved and the involved pair. The incidence of immunoparesis depends on the diagnosis. In the MGAS population, we can see immunoparesis, classical immunoparesis, about in 25% of patients. This percentage is increasing to the severity of the monoclonal gammopathy and is almost 100% in relapse of refractory multiple myeloma. This is a series of multiple myeloma with 242 patients in which we demonstrated a classical immunoparesis in 81.4% of patients. This was also related to the staging, was increasing with the advanced stages. And in the Cox model, we can see that in this study, the classical immunoparesis is an independent prognostic factor besides the age, the ECOG, the serum cholesterolemia, and the presence of 1Q gain in the FISH study. We are talking about the prognostic impact of immunoparesis in multiple myeloma. The first consequence of immunoparesis, logically, is an increased risk of infection. Patients with multiple myeloma have about 7 or 10-fold increase in the risk of infection, whereas MGUS patients have 2 times only. In precursor diseases, the immunoparesis is associated with a risk of progression. And in patients with newly diagnosed multiple myeloma, several studies have demonstrated an increase and poor outcome in terms of PFS or OS. And in the last study we commented previously, we have also an increased risk of early mortality. This is a study of 85 patients which are undergoing autologous stem cell transplant, and in this case, the immunoparesis, when measured with the Hevylite test, demonstrated an impact in PFS, but when we measure immunoparesis by the classical way, we can't demonstrate this impact. This is a very interesting study in 115 patients with newly diagnosed multiple myeloma. We can see severe IMA and extreme IMA associated with an increased risk of bloodstream infection. 21 patients had this kind of infection in the first 6 months of the follow-up, and 58 of them died. So the risk factors for early mortality were age higher than 65, the extreme uninvolved suppression, and the bloodstream infection. We can see that patients with the 3 factors at the same time had a very dismal prognosis. Well, if immunoparesis is a bad prognostic factor, is this logical that the recovery of this immunoparesis is a good factor? In this study of the group of Salamanca, in more than 400 patients, they demonstrated classical immunoparesis in 81.2% of patients, and the recovery of this immunoparesis was in 24 patients. These patients had better progression-free survival and overall survival. Probably this is the most important study to date in the field. This is a study of the Spanish group of myeloma in a clinical trial, the GEM 2014 main, which is a clinical trial of maintenance therapy in these patients. We compare the classical immunoparesis with the IMI, and we can see that the percentage of patients with IMI is higher because the higher sensitivity, and the recovery is also higher than when measured with classical immunoparesis. The patients we have with an uninvolved immunoparesis had a poor outcome in terms of PFS. And more importantly, this study was able to add value to the information we have according to the minimal residual disease. This study has been accepted to publish in Hematology. How can we manage the immunoparesis? From a clinical point of view, the best goal we can achieve in the clinical setting is the achievement and maintaining a deep response, because this situation is associated with an immunoparesis recovery. Of course, we also have the vaccination, the antibiotic prophylaxis, the antiviral prophylaxis, and very interestingly, currently we have an explosion that immunoglobulin replacement with new therapies. We have new challenge ahead. Infection probably is the most important of them. With the use of bispecific antibodies, teclistamab, talquetamab, elranatamab, linvoseltamab, etc., we are witnessing an increase in the risk of infection, which is the main cause of morbidity and mortality in multiple myeloma, particularly grade 3 or 4 infection. It's also related to the CAR T cells. This risk of infection is time-dependent and is the main concern currently, besides the cytokine release syndrome and the neurotoxicity, the ICANS, with the new therapies. To conclude, we can measure immunoparesis by the classical methods, which is defined by the presence of a reduced level of one or more uninvolved polyclonal immunoglobulins, or by the IMI method, which points out a reduced level of the uninvolved polyclonal pair. The rate of immunoparesis is changing through the full range of monoclonal gammopathies, and in the case of multiple myeloma is higher than 80%. Immunoparesis is a consequence of the underlying immune dysfunction, but is also aggravated by the treatment. Hevylite is a simple, validated, automated, and convenient immunoassay showing more sensitivity and efficiency than conventional methods for the assessment of immunoparesis in patients with intact immunoglobulin multiple myeloma. This is a better biomarker of monoclonality. IMI is a poor and independent prognostic factor in terms of PFS and OS in newly diagnosed multiple myeloma in most studies. The extreme IMI has been associated to severe infection and early mortality. Infection is currently an unmet clinical need in multiple myeloma, remaining the leading cause of morbidity and mortality, even more in the immunotherapy era, with the intensive use of CAR T cells and bispecific antibodies. Every effort should be made to avoid infection in our patients. Thank you very much for your attention. I have put my mail here for keep in touch. But if you have any question, I'll be delighted to try to answer. Well, thank you.